So with the pre-pregnancy counseling, the concepts really are, identify what is your disease activity, what is your nutritional status. I think about, medication failures and successes. And in part also, I talk about medication safety, because our moms are going to come in, or our future moms are going to come in needing the reassurance that actually it's okay to be on these medications because they want to go off of them. I also tell them that imaging and procedures during pregnancy, if clinically indicated, will be fine. It's important, okay? So again, I said earlier today, there are really 2 slides to my talk, which is that really do what you need to do, okay? Delivery planning really is dependent on disease location. We also need reassurance to them that breastfeeding is safe. And when we actually first started to introduce biologics, and I started to have deliveries and send our postpartum moms into our newborn nursery in our newborn area with having this medication profile, our lactation specialists were like, oh my God, and our pediatricians are going, oh my gosh. So part of my job also is to basically provide assurance and confidence that you can do all of this. And then of course, the new discussion about the newborn and early childhood vaccines. So as we go down, what are the strongest predictors for outcome? At the end of the day, it's disease activity. So if you come in with active disease, you are definitely at risk for miscarriage, you're definitely at risk for disease exacerbation, and therefore you are definitely at risk for preterm delivery. And it's intuitive, right? Poor fetal growth, if you're ill during the pregnancy, leading to preterm delivery, cesarean section, which is not ideal when you have a mom who is in active disease, and obviously stillbirths. So, and when you actually look at the studies that compare outcomes in women who have IBD, who are in remission versus controls, there's no difference in their outcomes. So the idea really is that you've got to send mom in remission. And, as a general rule, it just feels intuitively comfortable that 3 to 6 months of remission before conception seems to be reasonable. Okay, procedures and imaging. I really hope that people walk away from today with the concept and the confidence that you need to do what you need to do to identify what's going on with the mom if you think the mom is really sick. Okay. You need that information so that you can treat her appropriately, because again, the word is, in order to have a healthy baby, you must have a healthy mom. And I will also hope that you understand that a 32-weeker is not a successful pregnancy, a 34-weeker is not a successful pregnancy, a 36-weeker is not a successful pregnancy. So I think that the idea that somebody says, oh yeah, we can just get her to 32 weeks and deliver her, that's not okay. Okay. There are 8 more weeks of neurological development for that kid that needs to happen. And it cannot happen as well in the IC, in the NICU, as it is in mom. Okay. So we gotta work really hard as a group together with your OBs and with your MFMs to basically get that pregnancy through. So you need to do what you need to do. There are very, very few things that is harmful to a pregnancy. There really, truly is very little things that's harmful. So if you need to do endoscopy, do it. Okay. The sedation that's required, most of the, first of all, it's a short, limited procedure. The sedation that we give them is not going to hurt them. Okay. Your benzodiazepines are not going to cause cleft lip and palate. Okay. The palate and the lips were formed at 4 weeks of gestation, 5 weeks of gestation. You're way past that. Don't worry about it. Okay. The heart's already formed. Don't worry about it. Okay. So I think that in terms of surgery, I alluded to earlier that if we had our choice, if we needed to do something, and it is happening in the 2nd trimester, don't delay it. Don't think, oh, I think I can get her through to 28 weeks and then we'll go and deliver her. The answer is no. If you need to do something at 22 and 23 weeks, get it done. It's just get it done. We'll help you with it. I mean, if you need steroids, you do it, get it done. All of the other medications, again, with the exception of methotrexate, has been identified to really be safe. We know that Cimzia, because it has an FAB fragment, basically can't cross the placenta. And so there's some really good studies that basically have determined and confirmed it doesn't cross the placenta. So that, of all the biologics, that's the only drug that doesn't cross the placenta. All the other ones do. There is active transport actually through of the other biologics through the placenta. However, the studies so far of fetal outcomes and newborn outcomes have not demonstrated any poor outcome or detrimental effects in fetal exposure. So the biologics is, from my perspective, anyone who comes in with any of those that keeps her in remission is totally fine with me. Delivery decisions. It's really based on the degree of, and location of mom's disease. So if she doesn't really have any, abdominal surgeries and fistulas, then basically there's no reason that she shouldn't have a vaginal delivery. She can push, et cetera, et cetera. So the termed planned C-sections, however, are definitely for moms who have, perianal disease, significant fistula disease. We're not going down there with a vaginal delivery. And then the other one is a mom who has had significant abdominal surgeries where I'm really concerned that there are going to be multiple adhesions. We cannot do a crash C-section on that mom. So those are going to be planned C-sections.